if you don't have the underlying support for it, it's going to fail right out the door. It's going to totally disrupt patient care.
Hello, this is Zach with the American Journal of Healthcare Strategy, and you are listening to the Clinicians and Leadership podcast, where we focus on empowering clinicians from bedside to boardroom. Today, I have the pleasure of being joined by Miss Mary Russell. Miss Russell, why don't you take a second to introduce yourself? Tell us a little bit about your experience in your current role and the ways that you are serving now.
Yeah, thank you so much, Zach, for this opportunity. I really do appreciate it. I'm Mary Russell. I am a registered nurse. I have been a nurse for 37 years. I have had diverse clinical experiences. I am a retired captain from the United States Navy Nurse Corps, proudly served. And I have been working with Clinicomp International, an EHR vendor, for the last little over 14 years. I am the senior director for our clinical services and have traveled to all of our customers around the world over the last 14 years. And it is my passion to deliver technology solutions to my fellow clinicians at the bedside and help them provide the best care possible for all of their patients each and every day.
Well, Miss Russell, we are thrilled to have you on the Clinicians and Leadership podcast, and just thank you for your service to our country and what you've done as well, just for the service within the healthcare field. It's exciting to have you on to get the opportunity to pick your brain a little bit about some topics as well.
Yeah.
So one of the first questions that I have for you, Miss Russell, is, and I'm excited to dive into this. I think your combination of extensive clinical experience as well as your experience with Clinicomp and working in the EHR and in the technology aspect of healthcare, I think is a great combination that speaks to this topic that is very prevalent, and which is these administrative burdens, burnouts, like issues that plague every single healthcare organization and hospital system across this country. And so there was a Stanford medicine poll that we talked about previously that polled hospital-based physicians about the amount of time that they spend on each patient. And further, then that poll broke down the amount of time that those physicians spent on each patient, but doing specific tasks. And what it found is that hospital-based physicians reported that they spent on average 37 minutes on behalf of each patient. So on a patient total. But 25 of that 37 minutes was spent in the EHR, navigating the EHR, working on that documentation. And documentation is important. That's a critical component. So we can't completely get rid of that. But spending twice the amount of time as you are with the patient on the EHR is that's quite a lot of time and contributes to that administrative burden that we see. And so I guess my question with that long introduction is how can healthcare leaders balance the need for EHR documentation, doing that well, with reducing administrative burdens that are faced by their clinical staff?
Yeah, I think it's a recurring theme we hear over and over, right? Highly publicized, all of the feelings of clinician burnout. And it's not just COVID anymore. I think for a long time it was easy to just say, well, it's COVID and COVID burned everybody out. But that's not the reality. The reality is that the everyday burdens of the administrative needs to generate revenue are burdensome to the clinicians at the bedside. And I think that, anybody in any profession, if you had 12 meaningful minutes out of 40 minutes in every part of your day, and you're working 10, 12 hours a day, you can understand how frustrating that is for everybody. I only got 12 meaningful minutes from my provider. I'm the patient. I'm the patient's family. I am, the consumer of this healthcare product. And so nobody's happy. And that's a problem, right? It's a full cycle of issues beyond just administrative tasks. The domino effects are incredible. And so, but it's not just the clinicians forcing these things down on the clinicians. Healthcare leaders are doing the best that they can in very uncertain economic times, right? They're really faced with a double-edged sword. The costs of providing patient care have risen over 3%, right? But the reimbursement from Medicare, for example, has been cut for this year by nearly 3%. And so you have this widening gap, right, of costs and
Mhm.
reimbursement. So how do you bridge that without forcing, your clinicians do more, right? We see more patients, shorten your surgical times, faster turnover in our ERs. But by the way, you have to chart, each and every one of these codes or we're not going to get paid. And so
Right.
it becomes this hectic cycle of revenue tail chasing, right? Um, and
Right.
so, in addition to that, I mean, so again, I live in the Pennsylvania area. We're one of the states who have one of the highest trends in mergers and acquisitions in hospital systems.
Mm.
So, if I took pride in working in that small rural hospital, right? I love my job. I go to my job every day. I have a great amount of satisfaction. I know all my patients and my people. I know my administrators. And now I've been bought out by this conglomerate healthcare system in my state. And suddenly I'm an employee of this huge healthcare system. That's more administrative burdens, right? Hospitals are
Right.
filing for bankruptcy, which is happening more and more frequently for a variety of reasons. Sometimes there were mismanagement, sometimes there were other things. And one of our large hospital systems just laid off 200 people and said, we're not sure if that's it. There may be more of you. So clinicians are working in unsteady streams right now. And the hospital leadership and executive leaders and financial leaders, COOs, CFOs, CEOs, CMIOs, CNIOs, they all have to make decisions that can be unpopular at times. But what they need to do to alleviate the burdens, that pressure, right, on the people who are at the bedside trying to provide the safest, most effective care possible to the patient population, there needs to be a buffer, right? You cannot just push and expect that people won't break. They'll bend for a time, but
Right.
eventually they will break, as we see more and more with these studies about burnout. So I think that as a leader, as a hospital leader, what you need to do first is understand, where are we losing money? Why are we losing money? How can we generate more money, right? Don't just tell the practitioners do more. Use the people that you have. Talk to your billers, your coders, your revenue cycle management, your EHR managers. Talk to all of them first. Find out what the problems are before you start pushing more administrative burdens and cutting patient visits and cutting services and trying to squeeze more and more out of the clinicians at the bedside. So I think that, before you add tasks, you need to understand what those are going to accomplish. As a leader, you really need to have a well formulated plan. You have to have an informed plan. We've lost this much revenue because of this, not just we've lost this much revenue. Um,
Mm.
and I think that honestly, I think, sometimes we forget about the simple solutions to things. I think that everybody thinks technology is the answer to everything, right? Just buy more technology, buy a better EHR, buy, a better physiologic monitor, ventilator, whatever it might be. People think that's just going to make it easier because you're going to get more data and that'll be great. But that's not really the truth. The truth is that the providers and clinicians still have to chart. They still have to document. They still have those 25 minutes of administrative time that they need to deal with. So why not cut it with human assets, right? Let's invest in less costly human assets like scribes, right? Someone who can round with me, start my charting for me, get everything teed up so that I can review it and sign it and concur. And that becomes the patient's medical record. All the while, I, as a practitioner, am talking to my patient, right? I'm not talking to the scribe. I'm not had my head down at the computer and my keyboard, talking to the patient. The scribe is charting for me. And then my, you know, administrative burden has been lessened. And make sure that whatever technology you're using, whatever EHR that is, it needs to support documentation that only requires me to chart something once. I should never have to chart something more than one time for the convenience of billers, coders, research people. Everybody wants a piece of my time, but I don't have it to give more, right? So make sure it's
Yeah.
smart, what you have. And Zach, as we know, everybody has a PhD from Google, right? But it's everybody knows everything because they saw it on Google. And so
Right.
I personally think that one of the timely administrative burdens for practitioners are spent dispelling bad medical information that people found on Google. I Googled it and now I know I have this disease. Why didn't you know this, Dr. Zach? So, I think that investing in patient teaching tools is a really smart way to spend money. That way, when the patients are writing in the portal and they're, saying, I am really sure I have this, you know, mortal disease and you thought I only had
Right.
needed a Band-Aid, you know, let the
Right.
ancillary people provide them with the tools of scientific based, evidence based information, let them read it and then come back to you. So adding those kind
Mhm.
of buffers where you plus up some of the ancillary administrative support with skilled staff and good teaching training tools, I think are really smart, efficient ways to eliminate some of these administrative burdens on the providers in the
Yeah.
field.
Well, Miss Russell, that's a great answer. And there's a lot of things that I think are that was just that piqued my interest throughout your answer, and I'm excited to dive into them over the course of the rest of this interview. But one of the things that first I think piqued my interest was this, and you put it really well. You said you can only push down so much, they will bend, but eventually they will break. And that is very much an issue that I think is commonly seen because that can be putting more tasks on your providers and your clinical staff can temporarily fix some of those issues or seemingly resolve some of those issues. But ultimately, like you just very clearly walked us through it, it has a negative impact on those clinical staff, on the clinical staff to the administration relationship between those two groups of individuals. And ultimately the patient as a whole. And so for those clinicians that have been bending for a substantial amount of time, maybe have you broken, but are experiencing that burnout, for leaders that are seeking to re-engage and retain them, what are some steps that those leaders can take? Because burnout is a thing, and there's things we're trying to do to reduce it in the future. But for those that are experiencing it, how can your healthcare leaders engage and re-engage those clinicians and that are overwhelmed by these administrative burdens?
Yeah, it's a great question, and it's certainly again it's a challenge. I'm empathetic to the leaders, but and in the end, they'll succeed. If I succeed, they succeed, right? So it's most important that we figure out how to bridge these gaps. And so I know it will sound cliche, but the number one thing you can do is listen, right? And so I think a clear indicator that providers feel that they're not being heard is this surge in collective bargaining, unionizing, right? The providers are doing that now because they want a bigger voice. They want to be heard at the highest levels. And interestingly enough, a lot of these collective bargaining union agreements are being reached by residents and fellows, right? So these are the new up and coming. So they don't even want to waste time not being heard. They're going to unionize and use their collective bargaining voice to be heard. And so it's a very interesting shift in the dynamics, right? And it's sounds like a clear message has been sent to them, the new and upcoming providers, that you're not going to be heard. So they're not going to tolerate it. So clearly, it needs to be addressed and they need to be reengaged. I think that one of my favorite jobs I had this. It was they had a newspaper. It wasn't just a little, a weekly paper that came out, and it was called Netma News. Netma News. The Netma News is out, and NETMA, and it stood for Nobody Ever Tells Me Anything. It was the best little way to communicate from the C-suite down. Like, it was literally called Netma News. And so Netma News would come out and we would hear all about, how we're doing and, what are some of the projects that are in the pipeline? What are the staffing, changes in staffing? Who's here? Things like that, never reach the bedside clinicians quite often. So I think that people like you, Zach, right? Like podcast within your hospital or some kind of app or some way that leadership can provide ongoing, transparent communication to the clinicians develops a sense of trust, right, throughout the hierarchy. And I think that is critical to re-engage people who feel disenfranchised already. And it also sends a message of hope to the young ones who've already unionized because they insist, on having this voice. And as a leader, as hard as it can be, you have to be transparent. I should not be an employee who reads our annual report and finds out that my hospital's in financial straits, right? If I worked there, I should know. I recently had to tell a friend that I read something about a hospital where she works and some acquisitions they were making. She's like, how come I don't know that? Right? She works there. So, and she's a provider. So I think that, leaders need to keep in mind the cost of replacing a provider and a nurse. If you replace one provider and one nurse, you're looking at hundreds of thousands of dollars just for that, plus lost productivity that comes along with it because now you're gapped to critical staff members. So I think it's really important to look long range, be transparent, be open, be honest, be willing to hear the opinions, and thoughts from everybody, because if they don't feel like they have a voice, they're never going to feel engaged and want to stay and, dedicate themselves to you and your success.
Miss Russell, I love the emphasis that you've put on the human connection within healthcare and how that is a critical component to reducing burnout and other administrative burdens, and simply just the act of listening and how that goes so far, and engaging and being clear and transparent. I love that word, and just how the impacts that can have on an organization and as a result patient care. And so
Right.
I'm just excited about that, and just that. I mean, like you said, so often we run to technology as oh, this is going to fix it. And it's
Right.
if you don't address those foundational issues prior to introducing new technology, then you're just putting another little Band-Aid over a wound that is not healing properly and is not going to heal properly. And so, I think that that's such a great point that was made. Shifting gears a little bit, because I do want to talk about technology just a little
Yeah.
bit. And so how do you approach the challenge of integrating a new technology into, or a new EHR, or a new innovative process into an existing system without disrupting operations, and as a result negatively impacting patient care? Because in the field of medicine, in the medical field, innovation is constantly happening, and people are constantly trying to improve, and should be
Mhm.
constantly trying to improve, and
Mhm.
and inevitably change must happen. And with new technologies coming out, there's a lot of exciting things on the horizon, but how do you implement those effectively without disrupting the present operations, and as a result, negatively impacting patient care?
It's a great question, right? And it's the ever burning question out there, right? Well, soon we'll be going to hymns. And so, it's just, hundreds of thousands of square feet of vendors selling fabulous IT, technological advanced support for your patient care. But I think that as a leader and anybody who's part of this decision making, you need to understand the system architecture you have now, right? So you you bolt on these other things to what you already have? Or is your architecture just not going to support that? So, step one, know what you have before you want to bolt something onto it. Make sure you really understand that. And then let's say I do want to bolt something onto it. Great. So, I buy this new equipment. Do I have biomed support to manage it, take care of it? Do they have the skills? Do I have the IT professionals who can program and make sure that it's going to be supported? So, with if you don't have the underlying support for it, it's going to fail right out the door. It's going to totally disrupt patient care. You should, I think that there's an expectation that there's always going to be downtime for things. And I think that's really where, as hospital leaders, you need to push your vendors because there should be no expectation of downtime to implement new technologies. There's no reason for that. As long as you've all agreed that your system architecture can support it, then as the vendor, your engineers need to make that happen. And as a hospital leader, I don't want to have to tell my staff, be prepared for downtime procedures because we're going to implement something new. That's just not, that's a bad plan from the start. And so I think that, again, you need to leverage your purchasing power and work with the vendors to make sure that what you're buying is going to be fully supported. And I think that the most important parts, once you have the technology and infrastructure straightened out, then the most important focus needs to be on the staff who are going to use this. Hopefully, you've had buy-in, right? I have literally been to hospitals where they implemented a new technology because one clinical area said, this is what we have to have. And then they just downstream said to another clinical area, oh, you have to use this because we bought it. So these people said, no, we're not going to use it. So, so millions of dollars of equipment sat wrapped in plastic, never used. They purchased a whole new system. Yeah. So the staff need time to be invested. They need to be educated. The training plan has to be well, uh, tailored to that specific community that you're training. It needs to be outcome based, evidence based training so that, you will get this technology online. They also need to have tactile time with this, right? As clinicians and practitioners, if I have to apply something to a patient, I need to touch that. I need to open the packaging. I need to feel it. I need to plug it in. I need to see how it works. As clinicians, we're already analytical people, right? We we want to know, we want to understand, we want to know the whys and the hows and the, and nothing will cause more frustration or negatively impact patient care than a practitioner who is coming to them already and saying, sorry, we're just rolling out this new thing today and it's just not going well, right? Well, the patient, and oh, by the way, I'm going to stick it on your body anyway. you know, you lose the trust of the patients, you lose the confidence of the practitioners trying to adopt this new technology. So make sure you plan adequately for the staff involved with this new technology to learn it in a classroom environment. Don't come to me at the bedside and hand me a new device and say, Mary, just plug this in your laptop and it's going to do X, Y, and Z. Okay, you're trained, and walk away from me, right? So make sure you pull the staff away from the bedside. Give them a hot minute in a classroom setting or a scenario based clinical setting, and let them learn this new device so that they can feel confident. The patients can feel confident, and you as the leaders are going to get the optimal output of your technology.
Right. Right. No, it sounds terrifying for the first time to be using a new device or system to be right in front of a patient in a patient room, and they're watching you fumble, and that's not building confidence in you and the care that that patient's going to receive, and as a result as well, that provider, if put in, or that clinician if put in that situation, isn't building confidence between them and the administration, because they're like, holy cow, they don't care about the
Yeah.
training and the implementation of this process. And so I think I think you identified several really key critical things, and I'm uh yeah, I think that's awesome. I think that's awesome. Well, Miss Russell, thank you so much for joining us today and just sharing your insights and a lot of very practical advice and applications on how your clinicians in leadership and other individuals within the leadership uh, field of healthcare can make a difference in reducing administrative burdens and reconnecting and re-engaging clinicians and their clinical staff, and as a result having dramatic impacts on patient care, on staff well-being, and patient outcomes. And so thank you so much for joining and sharing those insights and your expertise with us today. We really appreciate it.
Yeah, thank you so much for the time. I really appreciate it. It was really nice talking to you, Zach.